There we go. All right. Thanks everybody for joining the August APAC community call. Today we have a special guest, but before we hand that over, there's some logistic announcements to make and some OHDSI news to share. So first, news around the OHDSI APAC Symposium. There has been an email sent out on this, but the collaborator showcase submissions are now open. So this means you guys will have up until September 15th to submit your work to be showcased at the APAC Symposium in December. This year's collaborator showcase, you get to choose between whether you want to present as a poster or whether you want to present as a lightning talk, or you can apply for both. But one note to consider is you may choose to apply for both, but you may not get accepted for both, right? So this will be up to the review of the scientific review committee, and the notification that you will receive will tell you whether you're accepted for both in case you apply for both, or you just get accepted for the one that you've applied for. So this is a small change from the previous symposiums. We're accepting two types of abstract submissions, the format of the presentations. Review will be done after September 15th, between September 16th up until mid-October, and then the notification of acceptance will be going to you at the latest by October 31st. It doesn't mean it will go to you on the October 31st. So we'll do our best to review everything and get the acceptance sent out as soon as possible so people can start preparing for your travels, as I know this is sometimes required pretty much a few months in advance to the actual event. So FYI on the collaborator showcase, I'm just gonna pop up the form so that everybody knows what I'm talking about. So this is the link to the form. If you go here, it'll give you the same details that I've just explained around the structure, as well as the instructions on how to do this. It's the same as the global symposium's abstract submissions, right? You need to both submit this Google form as well as a PDF of the abstract that you are that your work is about, in which you'll need to attach into this form. So this is on the collaborator showcase. A few more news to share around the OHDSI APAC Symposium, right? So the overall event website is currently set up. Some of the details is being updated by the host of the event. So I don't know if Morning is here to add on to this, but the website can be accessed through the URL you're seeing here right now. It will, in essence, the website is containing information for both non-OHDSI stuff as well as the OHDSI stuff, because the event itself is co-hosted by both OHDSI as well as the Singapore AI Healthcare and Healthcare Expo. So it's a biannual event that Morning hosts, and this time we're co-hosting both OHDSI and that expo together. So this is the central website for both of the events, but there will be a landing page set up on OHDSI.org for our usual OHDSI community to go to and refer to. Another FYI is the registrations are also coming soon. The fees are fixed, but the page is currently being set up. So fees will be 488 Singapore dollars, which is equivalent to around 370 USD. Just an FYI for those who will be planning your travels, as well as getting funding if where needed. So this is news on the OHDSI APAC Symposium. I'll just do one last call out to Morning in case he's with us. No, I don't see him. Okay, I'll hand over the floor to Mui now so that she can share some news around the OHDSI Evidence Network. So I did pitch this in June, but I think Mui has some updates to share around the initiative.
I gotta unmute myself when I'm talking. Okay, can everybody see my screen? I'm using the excuse it's late on my side too. Okay, so Asieh, you could use that when you're up and you make mistakes, right? Both of us can use this excuse. So, hello. Like Someone said he might have brought this up already. He brought this up once already, but I want to share this again to try to see if we can encourage folks to really join the OHDSI Evidence Network. And it's real objective, right? So the OHDSI Evidence Network, its goal is really trying to document the different types of data assets that we have available in the community, and also be able to take it a step further and help ourselves with research, right? So when somebody has a question, they may want to know, hey, what sources might have, the right data for me, right? So by joining the OHDSI Evidence Network, you're able to help with some of that. Now, there is another initiative that's going on from the industry side, where we would like also to be able to utilize the OHDSI Evidence Network to help find partners who are interested in paid sponsor studies, right? So it's not just about open public studies, but also about paid sponsor studies. So what we would love is for more people to join. Of course, APAC here, we have lots of data that's already available. So we would love to see more APAC partners become a data partner organization. So a DPO, it could be an institution, it could be someone who owns or licenses data. And it has to be converted to a minimum of V5.3, right? And willing to generate the evidence to participate in network studies. And again, I put in quotes here the word network studies. It can be public, like we do with the multi-center studies, or it could be sponsor-led studies, okay? So how do you join? Right, what do you need to do? Joining a DPO, there are certain things we want you to do. And then also what we want to make sure folks are aware is not all information that you generate is put out there in the public for anyone to be able to search, okay? So for those, that might think, okay, this sounds familiar. It's really like a data catalog or a marketplace, right? That's what we're trying to create. It's an environment where we can see the different data sources that can be utilized for collaborative research, but also potential paid sponsorship, okay? It's quite simple. You really need to have the database in 5.3. And then if you can run this particular SQL and R package here, right? Make sure your company approves of it, and then also run the diagnosis R package against the data. Okay, it's really simple as that. Okay, so we're not asking for your data. We're just asking for an aggregate. Okay, and so when you run the R package, this is how it works. Basically, if you have problems, you can actually contact this evidence network at OHDSI.com, and they can help you with it. The R package shouldn't take more than 1 to 8 hours, depending on your environment, right? Like if I run it on my open claims, it might take up to the 8 hours because it's like trillions of transactions. Okay, but I run it on like our German data asset, it probably take less than an hour. Okay, because that's things like 500 gigabytes, and that's it. Okay. So on top of that, like I said, not all you're going to run all this information, but not all this information will be available publicly. Okay. When you finish running it, that data will be sent to the committee and at the coordinating center at Columbia, but all that data will be held privately. Then they will take some of that information and make that private, right? So as you can see here, data source and site-specific metadata will be held securely. What's going to be released are aggregated concept counts and the totals of the number of data sources per record. That's what's going to be made public. So this way we can't tell which data source is what. You don't have to be afraid that, hey, my data doesn't look as well as other people's, or like in our case, you're going to be opening up the doors to everybody to IQVIA's data, right? So those are things that we've taken into consideration to make sure people are wanting to join this network, but also feeling that the aggregated the data that they ran is secure. Okay, and no, I have not drank anything or anything, even though like it's 8:30, so I don't know what the heck is wrong with me. So we would love to get you guys to generate a database profile. Any questions? Well, this is what happens after you do this. So after you do this, you get an email, you get listed, and then you'll receive a report on the information that you put out there. Anybody, any questions?
Excuse me, Mo, I have a question.
Yep.
Yep, because I try to run the DB diagnostic. They two functions. The first one is DB profile, and the second one is DB diagnostic. So which one is appropriate first?
I would ask you to email these guys and ask that question. My job is only to do the presentation.
I'm with the hook from Team U. That's okay. I will connect.
I know who you are.
Yes, yeah, right. Okay.
Claire was supposed to do this, but unlike Asieh, Asieh is crazy, so she decided to come live, right? Claire's, it was 11 p.m. and I'm like, I can run the call for you. I can run it, but yeah. You can email her, or if you want to email me the question, I'll email them, right, for you, right, and then connect you.
Sure.
So if it's easier, just email me your questions, and then I will connect you with the folks, okay? If that's easier. I talked to them.
Okay, I will email to them. Yeah, thank you.
All right, thank you. Yeah, again, there's the email here. It's let me put this in the chat. Was because how this thing works. Yes, so ask while I'm typing.
No, so Fook, I think the DB profile is part of the DB diagnostics package, if I remember correctly. I'm not understanding your question, right? So
it's okay. Just email them, and they'll answer. They're there for you to support you. Okay.
Fair enough.
They would love to get more of these out there. So whatever question you have, email them, and they'll answer.
Yes. Okay. Thank you.
You're welcome. Any other question? I think that's the whole deck that I was supposed to go through. Yes. Okay. Yeah, that was the deck. There you go. Got any question? Oh, they even have office hours. See? Look at that. Tells you how much I pay attention to what I'm supposed to present. Okay. All right. Hopefully we see more. I know, like you said, some folks are on holiday, but I will keep cheering that the APAC side puts more of these into the evidence network, because me, we're not competitive. I like to see us beat out the Western side with the number of profiles that we can get into this evidence network. Okay. So
yes, we're not competitive. No, not at all.
I'm telling you, we're not competitive in any way, shape, or form. So, all right, Asieh, I think the floor is yours now.
Any last questions for Mui? she's deferred.
Don't ask that. Don't ask that. Just let Asieh have the floor, man. Come on, be nice to her.
Over to you, Asieh.
Thanks so much. So I didn't get the option to give my presentation to you, Mui.
You can hand it over if you want. I'll try to figure out how to talk about the oncology extension. I did do it once, like 5 years ago. So hey, maybe it'll refresh something. But yes, a computer science person is very eligible to do a oncology extension presentation. Okay, girl. Yes.
But thanks for having me here. And very nice to meet those who I haven't met yet. Okay, I am going to share my. Should I introduce myself or not?
Please, Asieh. Like, I know you're a figure in OHDSI, but
wow,
it's very APAC culture to do a formal introduction of yourself. So please.
Okay, Asieh the figure. No, thanks. So hi everyone, Asieh Golozar. So very, very specific to what we do. I'm not that good in talking about myself, so I'm going to keep it very, very short. I put a lot of hats during the day, and but for this specific topic and this specific conversation, I'm here as the lead for the oncology work group within OHDSI. Been involved in the work for the past, I don't know how many years, 6, 7 years, pretty much a little bit after the work group was formed. And yeah, that's what I do when I don't have to do anything else, which makes life quite fun. I have a presentation, so I'm gonna just give you an overview, and I was not sure how much people know about the work group and what we do and what happens and why is it that we think we're special enough to have a specific work group. So I've tried to cover some of the basics, but let's do that, and also try to touch on a couple of things that are ongoing that are important for folks to know, that I would like to see collaboration from APAC. I see names of former and current collaborators, but it would be great to have more of them. But if you have any question, please raise your hand. We can just keep it interactive, and then I can stop and we can discuss and then we move forward. Let me first try to share my screen because I don't know whether it's going to work here. Can you see that?
Yes.
Cool, cool, cool. Okay. So, I'm just gonna start with talking a little bit about oncology and why is it that we do some work and spend some time in the OHDSI in general, in the oncology work group to do specific works in the field of oncology. You guys are all in the Asia or APAC community call, so I don't really need to sell the value of OMA. You know everything about it. You probably know it better than I do. So you've already drank the Kool-Aid, so I'm going to skip all of that. But basically, we know that the community work, OHDSI works, we have shown the capability of the network of the community in generating high quality evidence at scale across on different topic areas. And these are some of the secret sauce. We're all together. We are a community. We do open science. It's an open source community. We use standards. We can generate reproducible evidence, and we can generate evidence at scale. There are a lot of examples, so I'm not going to go through them and bore you. And I'm sure you know them more than I do. But then the biggest question is that, okay, OHDSI became 10 years old last December, has done a lot. You have all the analytics, we have OMAP, CDM, and then the conventions and the vocabularies. So the biggest question is that, why do we need an oncology work group? And what's different in oncology compared to rest of the medicine? Besides the fact, and a little bit of a joke, and sometimes not, people who do oncology think that they're very different than the rest of the world, but that's up for discussion. Anyways, there are three different big problems when it comes to oncology as compared to other disease area. I'm just going to compare it to diabetes, for example. One of the biggest problem and the main problem that we generally deal with every day is that we're dealing with a rare disease. It's big, the second most common cause of death in the world after cardiovascular diseases. The moment you get to your patient population, it becomes rare. So this is just a snapshot of a label for Tabrecta, which is a MET exon, which is a TKI approved for treatment of metastatic non-small cell lung cancer patients who have MET exon 14 skipping mutation. Sounds pretty good. If you look at the numbers, globally, you have 2 million new cases of lung cancer every year, which is quite a lot. Only 85% of non-small cell lung cancer, 70% of the 85% development are metastatic. Only 55 have adenocarcinoma, and among this subset, less than 1% have MET exon 14 mutation. So all of a sudden, from the 2 million cases globally, you end up with 7,000 cases each year across the globe, which means that within each of your institution, you're probably going to see a handful, a couple each year. That creates a problem. You cannot look into your data and ask a question of what is the overall survival of my patient, or who are my patients, how are they being treated with? That's our biggest problem. And then it gets even worse because now, we see more and more indications of co-mutations. So you have MET exon 14, 720, and then like they have to have like one of these other ones, and then they have to be treated. So good luck with finding patients. And as we get to know more and more about the disease, and as like there are more drugs that are approved for later stage diseases, this picture is becoming more drastic. The other problem is that we need a lot more detail compared to any other disease area if I want to do diabetes research compared to cancer research. Going back to the same question, non-small cell lung cancer, it's very, very common to ask questions about the overall survival of patients or progression-free survival, the two most or the most common outcomes in any oncology research. So a simple question can be, what is the overall survival of patients with metastatic non-small cell lung cancer with confirmed MET exon 14 skipping mutation who received oral capmatinib as first-line treatment? So we hear a lot about phenotyping and identifying like the specific groups of patients that we want to study. So if you want to do that here, just to identify my target population or target cohort, to start asking the question of how long do they live, I need a lot more information. If it was diabetes, I needed to identify patients with diabetes or patients with diabetes treated, for example, with semaglutide. Right now, I need to be able to identify the histology of the disease. So it's not lung cancer. It is a lung cancer with a specific histology. Also, it occurs in lung, so I need to know where it occurs. I need to have information of like a lot of information about the attribute of the disease. It's not any non-small cell lung cancer. It is metastatic lung cancer. Have to have the genetic information. Need to be able to identify those who have received a line of treatment. So I have to be able to get that information and not any treatment. This has to be capmatinib. So for my phenotyping, just the amount of detail that I need are all of a sudden way more compared to any other types of phenotype that we create. This is before doing the gymnastic to try to identify that, because we usually come up with these definitions because the data is not complete or the data doesn't contain what we have. The problem with these, with the details, is that they're not even available in the general data. They're there, they're hidden deep in the text. So you either have to extract it, like chart review or NLP, or there's somewhere else you need to link them. So it's not an easy job to say that I have my data, so I can just like combine this information to identify that. And then the other problem is that there are no standards, there are no common or even good terminologies to represent all of the details that we want. So there's some, for example, for histology or the topography or the anatomy and anatomical side of the tumor that are in ICDO and SNOMED, but not comprehensive. We don't have proper terminology for things such as the extent of the disease or dynamic nature of the disease. The genomic variants and their representations are all over the place. You can't find a standard that you can reliably use across the board in any observational research and get the same thing. And for things such as treatment episodes or treatment regimens, we don't have much. So numbers, details, and lack of terminologies and standards. That's pretty much why we got together when we got together. So a group of folks sitting there and saying that, okay, like we want to do cancer research. We're very interested to answer these kind of questions, but we can't do that. And we have to come up with solution. So figuring out what the problem space is, then trying to find what are the potential solutions as we're working through that. And that's pretty much like the basis of the oncology work group. Constantly jumping in the problem space, again, evaluating, and then trying to identify the solutions. So the first is the oncology network, right? So you can actually have an oncology network or an OHDSI network, exactly like what Mui just talked about. If we have a network of data partners and institutions that have data and have data in the same format in OMAP, all of a sudden, like those little pieces of pie of tiny little counts of patients with like non-small cell lung cancer, MET exon 14, like a handful here, handful there, can come together and can form a much larger sort of like size of the patient size. It's 11 p.m., so I'm gonna miss some words. Then you can actually try to look into it and make some meaningful evidence. So looking at like the bigger piece, combining these pieces or putting the pieces together can enable you to do proper evidence generation. If not, all we can do is probably case reports or case series. The other piece was trying to assess or addressing the limitations of details and terminologies. And this was pretty much like what is right now called the oncology conventions, used to be called oncology extension of OMAP. And there was a reason for that. We started by identifying the problems and trying to test, play around to find solutions. For that, we needed to call it extension because we didn't want to like make it public and say this is the way to do that. That was back in the day. We introduced the extension at the beginning of COVID. I lost track of time. And right now, everything that is a part of oncology and anything that was introduced as the oncology extension is a part of OMAP. So we're not any different from anything else at OMAP, except that we have specific convention on how to represent the disease, how to represent treatments. And the only probably other difference that we have is that through the work, we introduced 2 other tables to OMAP episode and episode table and episode event table that allows to do a lot of work. So the conventions, or what used to be called extension or module, are developed to solve all the problems that we're dealing with oncology, right? Specifically the details and the granularity and representation and all that. So there's 3 big components of the convention. One is called cancer disease model. That's basically a convention of how to represent a disease. We define a disease as an oncology-specific disease, like our example, non-small cell lung cancer, metastatic non-small cell lung cancer with mixed MET-exon 14 skipping mutation, as a combination of base diagnosis, that is how diseases are being represented in oncology. Where is it happening? The anatomy. What is the histology? That is called base diagnosis. Plus a set of diagnostic modifiers that tells you a lot about the attributes of the disease. Whether it is metastatic, there is a mutation in exon 14. If you were looking for stage, you can add that. That can be like involvement of lymph node, site of metastases. Is it 2 centimeters or 7 centimeters? So any information that talks about the attribute or the characteristics of that base diagnosis is defined and represented through diagnostic modifiers. And there are one too many connections between them. One diagnosis can have connection with many diagnostic modifiers, and I'll show you in a bit how it works. The second is cancer treatment model. That's one feature that's quite unique and quite important in oncology, is that treatment in oncology are often a set or a combination of treatment that are scheduled and delivered like in a timely fashion. So and the way you want to represent it is to actually look at these combinations, which are called treatment regimens or lines of therapy, as opposed to looking at the individual level data, right? So looking at cisplatin alone doesn't give you enough information of how patients are doing if a patient was put on a regimen of cisplatin plus gemcitabine plus bevacizumab, for example. So the convention allows you to represent treatment at a composite level. That's through the episodes. We're calling it treatment episodes, or at the individual level. Sometimes all you want to look is to see and report and assess is the proportion of patients who receive prostatectomy. Those can be done through standard OMAP approach and looking at procedures and developing the phenotype accordingly. And last, finally, probably quite important, the most important piece, our cancer disease model, the episode model. So that was the reason for the introduction of the episode table and episode event table. Episodes are basically, as the name says, are continuous periods of disease or treatment that have a very, very specific meaning, right? A metastatic disease episode is an episode with a start date and an end date, a period of time that within this period of time, the patient is considered metastatic. Same with cisplatin, gemcitabine, bevacizumab treatment episodes. That's exactly a time, like a period of time that the patient has been under this regimen. The episodes are composed of multiple events, and they're essential for conducting cancer research. So if you want to just go through it one by one, this is basically how the cancer disease model is represented. As I said, a condition is a combination of, or a cancer diagnosis is a combination of the base diagnosis, histology plus topology, non-small cell plus lung, plus a set of diagnostic modifiers, like stage, grade, margin of tumor, dimensions, extension, biomarker status, metastases, location of metastases, and you can name it. The base diagnosis is represented in the condition conditions, they're in the condition table, and then diagnostic modifiers are measurements. The cancer treatment model allows you to look at individual treatment information, if that is meaningful and if that is what you want to do in your study, and at the same time enables you to try to answer questions on like, what did the patient receive as the first line of treatment or as the first regimen? After diagnosis with metastatic non-small cell lung cancer, how many cycles did they get? And then you can go deep further on the dose and everything else. Currently, in the current form of OMAP, you can get that. This is available in the data. You have the data of administration, and then you can easily look into like how many like build drug errors and report that, or do what all the fancy things that we can do. We don't have this. And there are a lot of works that are happening within the community, within the work group. I'm just going to talk about one, but I know that our colleagues in UNSW are also working on another approach to enable derivation of regimens from individual drugs, cycles, dose, and everything else. So you can start looking at composite level and answer important questions in oncology. And finally, episodes. So I told you what episodes are. One question is that where do we get the episodes? They're not available in the data. The convention allows you to represent it, but it has to be either derived or it has to come from another source. Sometimes you have it. Sometimes you have oncology specific data that has these specific information about like the period of metastatic disease or when a patient has an episode of progression or recurrence and all that, so you can populate it if it's available in the data. Otherwise, it needs to either be algorithmically derived through NLP or through other sources such as registries. With diseases, we have a parent episode that's called episode of care that covers the entire cancer duration from the time that the patient was first diagnosed and appeared in the database with that specific diagnosis through end of life, either end of your database or if there's a date of death. And the episodes can also have children. The two specific children of disease episodes are disease dynamic, that talks about the dynamic nature of the disease, whether we observe a remission of the cancer, whether the cancer is getting worse, we call it progression, or it hasn't changed, it's stable. And also the extent of the disease. So whether it's a confined disease, the disease confined within the same anatomy, so it hasn't spread outside, for example, the borders of lung. Invasive, whether there is local invasion to the local lymph node or the neighboring organs, and also metastatic, which define like a widespread the spread of disease across the body. We have a set of convention for all of that that's currently available in our wiki, and very specifically recently we worked on the episodes and conventions for the episodes that are available. I put the link here so you can actually take a look. So if you look at the schematic patient journey, the typical, and this is a very, very, very simplified way, picture, things are not as straightforward as this shows. But usually there's a diagnosis. At some point, the patient gets worse. They start like developing metastases, then the disease become metastatic. There are some evaluation of biomarker. Do you have exon 14? Do you have KRAS? Do you have EGFR? All of those things in the context of, for example, lung cancer. And then there's some decisions that are happening on what treatment should the patient be on. So the first line of treatment starts at some point after diagnosis, and until, for example, the patient progressed. There are other reasons to stop the treatment, but in this context, there is a progression. The disease has been spread to, I don't know, bone and lung and other organs. The medication, the regimen is not working. The drug is, the regimen is discontinued. And then the patients are being put in another one. After a while, you might see another progression event and then discontinuation of treatment. And this can continue until end of life, end of observation, hospice, palliative care, and all that. So this is what we typically see as simplified pictures. And if we want to apply the episode model, you can basically here say that this is the episode of care of lung cancer from diagnosis till end of life, or till when we see the patients. From the time the patient is diagnosed with metastatic disease, the extent of the disease, or how advanced, how spread it is, it's become metastatic. So from this time till the time that we see that once you get you become metastatic, you never go back. You're always metastatic. You have an metastatic extent. And any time that the disease gets worse, so for example, here, from the time that you have a locally advanced or a localized, like earlier stage lung cancer to stage 4 lung cancer, you're getting worse. There's an episode of progression here. There's another episode of progression here, and then here. So all of these are, I don't know, not why not aligned, but any time that the patients are getting worse, there is the dynamic nature of the disease changes, and the disease become like you can see and define a progression episode. And then treatments. Remember, we can derive this information and then identify the period of time that the patient is under first line of treatment or getting this specific regimen and the second line of treatment. So all of a sudden, this schematic picture becomes something like that. So start and end of these periods of event. And then if I want to ask question, I can simply look at these start and end dates and ask a series of questions. I can look into the overall survival from the time of diagnosis, overall survival from time of metastatic disease. You can look at progression-free survival after first line of treatment with the, like regimen 1 and A1 and B. So from the time that treatment has started until progression, death, or end of follow-up, whichever comes apart. So this is from start of the first line treatment episode till this progression. You can look at time to next line of treatment, time to treatment continuation. You can actually look at the value, predictive or prognostic value of specific biomarkers. So the model allows you to do that very more reliably in a very straightforward fashion and answer all the use cases that we generally have in oncology. That is generally the gist of what the or the delivery of the oncology work group and the biggest conventions that we need to follow to make sure that we can do real oncology research. We also talked about terminologies and lack of availability of proper terminologies or complete or comprehensive terminologies. So the conventions in terms of representation for base diagnosis, we use ICD-10. And for diagnostic modifiers, we're using cancer modifiers as the vocabulary, and OMAP genomic to represent all the omics information. So that's like any measurement that has happened at the protein level, at the gene level, variation at the chromosome. These are all called OMAP genomic vocabulary. These are all built de novo. For treatment representation, for treatment episode, we're using HemOnc as a standard vocabulary. And we also created de novo vocabularies to represent overarching disease episode or episode of care. and dynamic and extent disease episodes, which are remission. For dynamic, we have remission, stable, and progression. And for extent, we have confined, invasive, and metastatic. We also worked a lot on representing genomic variants. It's quite important these days if you really want to do an oncology research and you don't have genomic information, someone will frown upon you. There are more and more indications that are biomarker dependency. You need to be able to have it in the data, to have it in OMAP and be able to use it. And for this, we need to actually turn these genomic markers into features that we can use in an analytic database, right? So example of MET exon 14 skipping mutation. This is a splice region variant on chromosome 7 at this specific location. And what has happened is a missing of exon 14. This is what you get in a very, very interesting fashion, like not something we're used to as those who are working with observational data. For this to be able to be used in any observational study, you need to turn it into a feature. So basically, at the end of the day, you have a database that you can say that like patient 8 has like feature 5, patient 17 has feature 2, and the others didn't have it or they did not measure it. The moment that becomes a feature, you can apply the standard OHDSI tools, everything that we use to generate evidence, you can use it for genomic feature to answer any variety of questions. And we've been working on the genomic a little bit more than any other fields because it's complicated, it's another world, so we have to make assumptions, we have to identify what is it that we want to represent and how should we represent it. I can talk about it for hours, but I'm gonna not do that, but please ask me questions or let me know and I can point you to relevant resources. But in general, one of our biggest problem was pretty much was, where do we start? What is a good, in OHDSI, we're not in the business of creating new vocabularies. We try to use and take advantage of the work that other communities have been doing. They have the knowledge, the expertise, and we can also benefit from that and create connections and collaborations. Kind of not possible in genomic. There are a lot of different knowledge bases, each having their own way for getting this information, representing it. The agreement between each of them are not that much. So sometimes you see very, very little agreement across the different knowledge bases. So we had to come up with certain decisions. Some are behind firewalls and not easily available. So the OMAP Genomics was built based on by combining the public repositories and knowledge bases, genomic knowledge bases that were available. So we surveyed, we find what was available, we put them all together, deduct them, create conventions, how to represent these features or these variants, what to represent, what level of information do we put there. And as of now, and this is, and then we did a huge rehaul and a huge update to genomic vocabulary this February. So as of now, we have around 290,000 genomic variants. All are available in Athena. They're represented under 5 different classes. And then we have like a hierarchy that I'm going to show you in terms of like how this is structured. So you can have representation at the level of a gene or at the level of DNA, which is divided in 2 different classes. Either structural DNA variants, or we have the small variants and gene amplification. These are gene DNA variants. You can represent variants at RNA level, either small RNA variants or RNA expressions, and also at the protein. These are small protein variants or protein expression. So the one in the middle follows the central dogma, which is small protein variants are translated from small RNA variants, which are transcribed from small DNA variant, fusion, or exon, and those are all gene variants. That is a central dogma that we follow, and we have other relationships here for RNA expression, protein expression, gene amplification, and the specific concept class that represents structural DNA variants. A typical example, this is just like if you look into the BRAF. So very common question is looking to be like different variation in BRAF. BRAF V600E is quite famous. This is pretty much how you see the hierarchical relationship, that if you have like a protein measurement with a substitution at position 594 of the two different amino acids, this the process actually during the mapping, you can create this hierarchy that to go from that to gene RNA variants, which is a transcription, which is substitution at a specific location between E and G, then going up to the chromosome, what happens at what position within which chromosome, to all of a sudden, like up there, tell you that what this variation is about with gene. So you can, at the end of the day, you can query at the gene level, give me all the variants, like the frequency of any variation within BRAF gene, give me the frequency of any variation that leads to like a downstream effect as a substitution in the specific position at BRAF protein, or you can query something right in the middle. We also worked on a tool that can help with ETLing this data to OMAP. Reason is that the structure of and the different formats that the genomic information comes are completely different than what we're used to. They need to be parsed out. This information needs to be actually extracted from the different sources and then mapped to OMAP. There are also sometimes ambiguity about the build of the genome, the reference genome that was used or that should be used to infer that level of information. And sometimes some of the some information are available or not. So the work group worked on development of a tool that is called ㅍOHDSI that supports mapping or helps or aims to help with mapping precise genomic variants to OMAP genomic. This is publicly available. It's a part of OHDSI. You can go visit that. The scripts are available. I want to invite you all, if you have genomic variants, to test it out, because that's the only way we can actually see how comprehensive the genomic vocabulary is, what we're missing, and what we need to add. Remember, there is no set that we know that this is what we need, that we have to represent. We have to build it based on what others have reported, and some of the things that you guys are using in your centers for genomic mappings, those are behind firewall. We don't have access to that. We don't actually know what the vendors are measuring. So we need your help to try to make the vocabulary more comprehensive. This is technically how ㅍOHDSI work. The input at the moment are VCF files. Also, you can have a text file and also JSON file. So the way it works is that so this is just an example of how it works with the VCF. The tool parse out the VCFs to generate the HGVS representation of all the variation that has been detected during the test, goes through the processing and report the HGVS representation. This is this convention that we use for representing the small variants in OMAP genomic. Once this is extracted and generated, this will be run through ClinGen allele registry to make sure that we can identify any other synonyms. So if a reference genome is different, that representation changes. But we're fortunate because we have ClinGen that contains all this information. So we match what we find in the VCF files or the HGVS representation with ClinGen, get the additional information, And then once we have everything, the tool maps it to OMAP vocabulary. You will get an output, a file with all the information of what is your variation, what was it mapped to, and if there's something that is missing, and also that is of important clinical relevance, we want you to tell us so we can add it in the vocabulary. The other big work that has been ongoing in the oncology work group is the continuous work that we've been doing on the derivation of treatment regimen. So the focus is quite important because, as I said, like it's kind of impossible to do a study and not talk about biomarkers. Also, everything that we do has most of the things that we do is very, very related to treatment. We want to detect the impact of the treatment, or how safe they are, how effective they are, and all of that. So going back to that picture or the cartoon that we have, and just thinking about the clinical trial endpoints that we want to actually assess also within like a real world setting to see whether like we can see the same thing, or whether drugs are working while administered outside of a clinical trial, or generally overall survival, symptom endpoints, disease-free or event-free survival, objective response rate, complete response progression-free survival. But all of that are pretty much dependent on a treatment. What is the overall survival following the initiation of a treatment, specific symptoms or adverse events of a treatment? Everything is treatment related. And treatment, as we said, we need to actually be able to combine them and derive information that like what is a regimen, and then be able to use that information to address these questions. So for us as a priority, that was a priority area. Again, like typical sort of approval that you see, a long list of like, need to be able to identify that and then do a lot of use cases. And unfortunately, this is impossible if you don't have treatment regimen. So I'll show you, this is a very, very simplified regimen cohort construction in Atlas. This is first line of therapy, and this is very simple, and it's absolutely irreproducible. We can assume that what happens if you want to do it more. So we've been working on another tool that does this. This is called Artemis. Basically gets the patient-reported data, patient data on drugs, derive the cycles, and from the cycles it drives the regimen. This is coming from a sequence alignment technique. I'm not going to go into the details, but happy to talk about that. So this is a process that you actually align DNAs and RNAs. We're using the same technology, but we also modified it in a way that we can actually address some of the issues, such as timing, that is very important in regimen. So this is a very simplified version to show that how the model works, but this is basically it. We've penalized, there's some penalties and temporality and all that. So we basically get the information of the drug of the patients, get the information of the regimen, and then we align the treatment information with regimen information. We pick the highest score regimen to call it the treatment regimen. We've tested it across 7 participating sites and done some improvements, and we're currently expanding it to be able to address different types of cancers. This is what you get at the end. You can easily define lines of therapy, look at changes in treatment, and do treatment characterization properly. So pretty much what we do with this, we can do studies. We can look into disease biology, diagnosis, mortality. I'm not going to go through that. This is basically all I talk. But in a population with very, very detailed information, the model allows you to do that. And you can do it at speed, with speed and scale. This is pretty much what we do in oncology work group. 3 specific subgroups that are focused on that. And the way we do it, and that's, I really want to emphasize that everything is defined, all the priorities is defined through analytic use cases. Analytic use cases are submitted by you guys. If you have a use case, let us know. It helps us prioritize the work so you can address your questions. This is the link to our use case repository, what is submitted so far. We've done some assessment, and we do this periodically to see to get an information on the use case requirement, vocabulary, and model readiness, and what's available in terms of data or algorithm, and the number of institutions that have that when we do these surveys during Symposium. So I really want you guys to do that. I know I went over time, so I'm trying to rush, and I'm very, very sorry. And that's it. So I hope I had convinced at least a few of you to come and join and also submit your use case. Yes.
Thanks, Asieh, for the presentation. I know we have a very few minutes left, but I actually have a very personal question. Not personal question, of question out of personal curiosity. So the episode table and the episode event tables, Asieh, you mentioned need to be algorithmically derived. Then does that mean in order to populate these tables, a lot of the population needs to be done manually, looking at the existing, so say we have an existing OMAP CDM in the version 5.3, and we want to start populating the episode table. Can any of this be done automatically, or to me, based on your presentation, it looks like it needs to be done manually?
It depends on your data. If you have it in your data, you can populate it. So
you're referring to the
algorithm,
episodes, right?
Episodes, right.
Yeah.
So
okay.
Some folks have lines of therapy in their data. If you have that, you can populate treatment episodes. Some people have progression information in their data. You can populate your disease dynamic episodes. Some people have information on metastases. So, or Artemis, for example, helps you to derive treatment episodes, right? So there is a place for that information, and that information is needed to do the research. How do you populate it for this specific is like through a series of gymnastics. So it's either algorithmically what's available. Some of the work that the NLP work group are doing is use cases. So it's NLP or doing some machine learning or model or combination of both those, or maybe at some point using LLMs or combining the data, right? So you get some information from path report. You can combine it with sometimes with radiotherapy or cancer registry along with EHR to get that. That's work.
Okay.
And that's something that we also need your help to move forward with.
Thanks for answering that. Chi also has his hands up. Chi?
Yeah, Asieh, for the central dogma slides.
Yeah.
What is a small RNA and small protein?
Sorry.
Right
This
there.
is an example, right? So small
the other
RNA.
one, the other slide.
Yeah, but this is an example. This is an example of a small RNA. So a substitution in specific position of one base to the other. So here A to G, or here small protein is like one amino acid to the other. That's a small protein, as opposed to you have things such as protein expression measurement, RNA expression. Those are not small, what do they call, small RNA variants.
Small RNA normally refers to a type of RNA that non-coding.
No, that's not non-coding. Yeah, no, that's not that. We have to clarify that.
Okay. Thank you.
Thank you, Chi, for your question. I don't mean to call you out, Jason, but you mentioned you had some questions for Asieh. Are you going to take that offline, or do you want the floor a few more minutes before Asieh goes to bed?
I will, because some of my colleague or students, they haven't joined today's meeting, but we will collect some questions and that you and email Asieh or you any other person to ask them. Thanks.
You're fine with questions through email, right, Asieh?
Oh yeah, please. If there's any question, feel free to send me an email, golozar@ohdsi.org. or ping me on Teams. I definitely respond.
Perfect. If no further questions from the community, thank you very much, Asieh, for attending us live. I know it's past midnight now. You should probably go to bed. We should let you go.
Probably.
Yeah, thank you so much again.
I have one announcement, sorry. If any of the folks on the call are planning to attend the OHDSI Symposium, the Global Symposium, and you're planning to come to the oncology workshop, please, please, please attend the 9 a.m. meeting US time, because we're going to talk about the plans, and I need everybody's help to make it work. It's going to be fun. But please make, if you can, please make it. It would be great to hear your perspective and then work together. Thank you so much again for having me. Enjoy
Thank
the
you
rest of
for
your
being
day.
with us, Asieh. Thank you.
Of course. Of course. Talk soon. Bye.
Thank you, everybody. Bye-bye. Enjoy your day ahead. And good night, Asieh.
Bye bye.
Thank you.